Dr. Sam Suri, and we have the co-founder of the South Asian Heart Center, Ashish Mathur, who's going to be talking to us. And we'll also hear from one of the health heroes who has gone through this program at the South Asia Heart Center, who's going to share with us her journey in trying to get healthy. There will be multiple slides which show the agenda with the sequence of the proceedings tonight. And you'll also see a short bio of our eminent speakers as we move along. Some of you familiar with the CWC know that the whole idea was to set up a platform to educate the public regarding wellness and to inspire the people to make changes in their lifestyle and their habits, and to actually empower them to make these changes, which will have a very positive impact on the community. So we'll start off with a talk by Dr. Molina, who's currently the medical director and the co-founder of the South Asian Heart Center in El Camino Hospital in Mountain View. And he's been in practice for several years, and he's essentially dedicated his life in this area, especially catering to the South Asian heart disease. In fact, he would very easily qualify for honorary citizenship in India or any of the South Asian countries. So without further ado, let me invite Dr. Cesar Molina to speak to us about heart disease, especially amongst South Asians. Please extend the warm welcome to Dr. Molina.
As mentioned, I'm a cardiologist. I've been a cardiologist at El Camino Hospital since 1990. I train as an interventional cardiologist. That is, I'm one of those cardiologists that are called to the emergency room when patients are having the worst day of their lives. And I'm asked to take patients to the cath lab and open up the artery that is actually leading to a heart attack. The interest in South Asian heart disease arose because we were seeing a lot of young South Asian engineers coming into the emergency room with myocardial infarctions. And that sort of prompted my personal interest, since most of these individuals did not have the classic risk factors for coronary artery disease that I was taught to in medical school. There were no smoking, they had normal blood pressures and things of that sort. That led to the introduction of the South Asian Heart Center about 14 years ago. And our mission is to reduce the high incidence of, initially was heart attacks, but subsequently also diabetes, with culturally tailored, science-based and lifestyle-focused services. So the South Asian Heart Center does not practice medicine or participants, and we have had 9,000 people enrolled in our program, are known as participants and are not known as patients. We do not provide them with an ICD-10 code, and they're not treated with medications. We actually assess their risks and then intervene from the lifestyle point of view, and then we let their physicians manage their clinical issues. Our program actually was the first of its nature. We actually followed CADI. CADI is an organization founded by Dr. Ines in Chicago, dedicated to the research of coronary artery disease in South Asians. He actually wrote a fantastic book sort of summarizing the whole topic. The South Asian Heart Center was actually created using his work. And we actually brought him in to give us the first talk to the medical community. Subsequently, we actually have been mainly a community-focused program, delivering services through trained volunteers from the community. And we have actually entered already into the American Heart Association scientific statement from 2018 as an example of community strategies in dealing with the epidemic of heart disease. Subsequently, other programs, as you can see here in the slide, have followed through and actually are trying and attempting to do the same. Our platform is actually very easy. We actually call it MEDS. Stands for Meditation, Exercise, Diet, and Sleep. It's science-based. There's a lot of beautiful science behind it. And we actually have created content dealing with the science behind meditation, exercise or physical activity, diet or nutrition, and sleep. We have then created 4 programs that actually are available to the community, initially available to only South Asians, but now they're available to anyone who is interested in taking advantage of our community services. We have Aim to Prevent, which involves assessing for risk factors, intervening, and then managing through coaching, lifestyle to improve the individuals, the participants' wellness, and subsequently, as a side effect, decrease their risk of cardiovascular disease and diabetes. We have Stop D, which is our diabetes prevention program that is CDC certified. It's actually one of the few in the San Francisco Bay Area. We also have created a Slim Fit program, which uses the language we have developed for the Stop Diabetes program to help people achieve their normal weight. These are individuals who actually have issues with weight, but are still metabolically healthy. Most recently, we have launched Aim to New Beginnings, where we actually providing these services to pregnant women and their young families to incorporate this platform into the family right at the beginning. This is actually our team. We have a scientific advisory council. You see here Dr. Alka Kanaya, professor at UCSF, and Dr. Latha Palaniappan, who's a professor at Stanford, who actually was a Stanford Fellow when the South Asian Heart Center started. Then down below, we have our volunteers and staff. And we have a good staff family, and everybody here is very much dedicated to finding the language to help our participants change so as to sort of enhance their sense of well-being. Now, this is actually a slide that was published by a Stanford cardiology fellow by the name of Dr. Paulo Jose, and showing the relative mortality rate, proportional mortality rates of different ethnic groups in America in reference to cardiovascular disease. On the top panel, you see females, and the South Asian female throughout from age 45 to age almost 100 have the higher incidence of cardiovascular disease proportional mortality. And the same is true down in the lower panel for males. Chinese and Koreans having the lowest incidence of cardiovascular disease mortality. Such that there is such a disparate global burden that, the Indian subcontinent accounts for about 17–18% of the world population, but 10 years ago accounted for 60% of the cardiovascular disease burden. Cardiac surgeons in India are very, very busy. And also we now see that there are dual epidemics, and the epidemic of diabetes, that it is thought that by 2030, half of the global population with diabetes will be located in India. Now, we actually talk a lot about risk factors. This is a slide that I'm just showing that when we look at cholesterol, and we do actually have a lipid-loving society, we think mainly that cardiovascular disease is caused by a high cholesterol. We can see here as we plot the LDL levels in about 140,000 patients admitted to the hospital in America with coronary artery disease, we can see that about 83% of those patients have cholesterol levels that are LDL below 130, which is actually thought to be normal. More interesting, 50% of those admitted actually had LDL levels below 100, and 20%, or 18% in fact, to be more accurate, had LDL levels below 70, which is actually the goal when you're taking statin therapy. And I show you this slide to just sort of demonstrate that we really do not know the real cause for cardiovascular disease. And from our research at the South Asian Heart Center, we think we can account for about 30%, testing everything that we have tested, and that 70% of coronary artery disease in the South Asian population and in other populations, in fact, is unexplained. Now, because of the limitations of blood pressure, cholesterol, and blood sugar that go into equations such as the PROCAM score in Europe or the Framingham score in the United States, we actually have looked at coronary calcification. The presence of coronary calcification on a heart scan or a CT scan of the chest is actually diagnostic of the presence of coronary artery disease. You can see here that using the Framingham score and using this German score, the PROCAM score, most of the heart attacks actually occurred in individuals who actually were thought to be in the intermediate risk for a heart attack. When you use coronary calcification, you find that most heart attacks occur in people who have the most coronary calcification. Therefore, rather than guessing, we have now moved to promoting the use of coronary calcification identification by CT scanning. And we suggest that men over the age of 40 and females over the age of 45 who are past their childbearing years consider coronary calcification as the best way to assess if they actually are at risk for a heart attack or not. The reason I'm showing you this slide is that if you have a score of 0, the likelihood of having a heart attack within the next 5 years is 1 in 1,000. So a score of 0 gives you a pass card for coronary artery events. The more coronary calcification you have, the higher the incidence of cardiovascular events as time goes forward. So this is actually a beautiful slide sort of demonstrating that coronary calcification can really identify the patient or the participant in this case at risk. Now, a little bit about our evolution, because we started testing for everything, testing for small particles of LDL, testing for inflammatory markers, not 1, but 2 or 3, and such. And what we have learned from the last 9,000 participants is that the best way to identify the person at risk is to find out, get the diagnosis by providing a heart scan. At El Camino Hospital, for most of the history of the South Asian Heart Center, participants could get a heart scan for $100, which is actually a significant fraction of what it would cost to get a very comprehensive metabolic panel. We have at the South Asian Heart Center, as a result of our work in the community, excuse me, assembled the largest research cohort, and we have about 9,000 people under study. In 2016, about 4 years ago, we started developing the Stop Diabetes program, because by then we realized that there was a dual epidemic and they were both very much connected with diabetes, and the factors leading to diabetes being the factors that were predisposing our subjects for coronary artery calcification. As we have evolved, we have actually studied everything here that is sort of listed in this slide, but we have placed most of the attention at assessment of lifestyle. We look at sleep, we look at exercise routine, we look at stress, and we look at nutrition. The interesting thing about the vegetarian diet is that you can either have a vegetable-based or green-based vegetarian diet or a grain-based vegetarian diet. A Coca-Cola and French fries is actually a vegan meal, but it's not what we consider to be a health-promoting, life-promoting nutritional program. We then had to develop a curriculum. How were we going to assess the high incidence of both diabetes and coronary artery disease in this population? And the way we went ahead we actually researched the literature. In 1980, there was a seminal paper published in Prevention that described a 25-year study looking at 7,000 subjects in Alameda County. And they followed them for 25 years and identified 7 factors associated with longevity and successful living. Successful living being able to be autonomous and free, able to do your own shopping, do your own gardening, take care of yourself. Those 7 factors were adequate sleep, 7 to 8 hours per night, regular vigorous physical activity, about 210 calories of physical activity per day, maintaining a recommended weight, not smoking, none or moderate alcohol consumption, eating breakfast daily, and eating meals regularly and not snacking. You know, you can see that grandma was right. Now, from this, you realize that 5 out of the 7 have to do with your mouth. Weight, smoking, alcohol consumption, breakfast, and eating meals regularly. Now, to the right here, you see that for a 45-year-old person, they had 3 or fewer of these lifestyle factors. You would expect that individual in this paper published in 1980 to live to the age of 67, 4 to 5 to the age of 73, and 6 to 7 to the age of 78. You do actually the math, you realize that there's an 11-year difference accounted for lifestyle. And when we continue to review the literature, we realize that the magic number is 12 years. You can add 12 years to your life expectancy, or you can subtract 12 years to your life expectancy, depending on how you live. So lifestyle, how you live, depends on how long and how well you live. Now, this is a paper that was published in the Journal of the American College of Cardiology in 2014. And this paper actually looked at 5 factors associated with a 79% reduction in heart attack. This was true even in the presence of hypertension and hypercholesterolemia. Those factors were a plant-rich diet, what they call a healthy diet, alcohol only in moderation, no smoking, physical activity, and a healthy body weight. Recognizing that the body weight or body mass index appears continuously in all factors associated with longevity, and as a result also physical activity and diet, which then lead to a healthy body weight. So the number here to remember is that you can see a 79% reduction in cardiac events in individuals who actually had those 5 lifestyle factors. When you look at that's a Swedish study. When you look at a German study, this is actually what they found, that lifestyle could reduce, on average, considering all diseases, about 78% of chronic illness. When you separate them, if you have a plant-rich diet, you're physically active, you don't smoke, and you have a normal body mass index, the incidence of diabetes is 93% lower. For heart attack is 81% lower. For stroke, the 3rd most common cause of death in America and the most common cause of disability in America, a 50% reduction. And for cancer, a 36% reduction. So you can see that these 4 chronic diseases that afflict us actually have a very significant lifestyle component. I show you the paper from Jack from the Swedish study. I show you this paper showing an 81% reduction. The fact is that there's a 79 to 81% reduction in cardiovascular disease, because there was also an American study, and that American study is called the ARIC trial. I'll show you that later. In reference to the INTERHEART trial, in the INTERHEART trial, they looked at 15,000 heart attacks across the world and compared them with 15,000 control individuals. And what they found was that individuals who did not smoke had about a 65% reduction in the risk of a heart attack. If they consumed fruits and vegetables daily, they had a 30% reduction in heart attack. If they were physically active, they had a 14% reduction in heart attack. If they consume alcohol in moderation, they had a 9% reduction in heart attack. But if you combine them, if you did not smoke and you actually had a fruit and vegetable rich diet, you had a 76% reduction in heart attack. If you added exercise, you had a 79% reduction in heart attack. And if you actually added a little bit of alcohol, you had an 81% reduction in the development of a heart attack. And that is actually, again, remember, 79 to 81%. And it shows in every single study. Now, this is the AREC trial. And this was actually a study that was published about changing lifestyle in midlife. So in the USA, just like in Germany, they actually look at 4 factors associated with good living. And that was the consumption of fruits and vegetables, 5 or more servings per day. A serving is half a cup. Most of us do not walk around with a cup, but we have a fist. So we can actually look at our fist and we can consider that a serving is half a fist. 2 servings is 1 full fist. So they look at fruits and vegetable consumption per day, regular physical activity, a body mass index, which was below obesity, that is up to 29.9, and not smoking. And in America, 8.5% of the population of this study, which represented the USA population, had those 4 healthy lifestyle habits. After 6 years, they were able to transform about 970 subjects of the study, and they were able to adopt those 4 healthy habits. So what happened to those who actually switch over versus those who did not? Well, within 4 years, there was a 40% all-cause mortality in those individuals who actually changed, and a 35% relative risk reduction in cardiovascular events within those 4 years. So that's major, that within 4 years, just by changing lifestyle in mid-age, you can actually affect your outcome. Now, how do lifestyle and behavior interact? And this is what this slide shows. This was actually published in 2011. And on the down over here, you actually see the ideal health behaviors. And right to the right, you see the ideal clinical factors. Those clinical factors include an ideal total cholesterol, an ideal blood pressure, an ideal blood glucose. Ideal health behaviors are not smoking, having a normal body mass index, not being overweight or obese. That is, for the typical non-Asian, would be a BMI below 25, being physically active, and having a plant-rich diet. You can see that the lowest incidence of cardiovascular events were in individuals who actually had those 4 clinical factors at goal, and who were actually had 3 to 4 of those good ideal lifestyle behaviors. But the interesting thing is that even if you actually had all of this not at the ideal range here on this line, in this, if you actually had some good 3 to 4 ideal lifestyle behaviors, you were able to significantly cut in half the incidence of cardiac events in individuals who flunked both on the health behaviors and on the clinical factors. Again, demonstrating that the way we live, despite poor clinical indices, does have an effect on our outcome. This is another seminal paper. This was actually this is the diabetes prevention paper. There were 2 papers published in the New England Journal of Medicine in 2002, one from Finland and one from the USA, showing the same thing, that if you take individuals, a group of individuals who were at risk for diabetes, and you actually provided lifestyle coaching in one group, metformin, a fantastic drug, in another group, or placebo, that after about 4 years, those who were just on a placebo, 33% would actually develop diabetes, but that we could decrease that number by 31% with metformin. But more importantly, within 2.8 years, there was a 58% drop in the development of diabetes in the individuals who had a heart health coach. The study was supposed to be a 5-year study, but had to be cut early at 2.8 years because they thought it unethical not to let the individuals on metformin and on placebo know that actually exercise and good nutrition was actually the key to the prevention of diabetes mellitus. They stopped the study at 2.8 years, but at 5 and 10 years, they have still found that difference. Now, as a result of this, we have actually, with this knowledge, with this content, created the Aim to Prevent. And we're a visually deployed prevention program. That is, at the beginning, you had to come to our center to get these services. Now you don't. Now we provide these services online. We have over 9,000 participants. You can see we have not really coded the map of the United States of America using political colors, but we are present in 38 states and in 7 corporations in the USA and in India. Some of them we do teaching, some of them we actually do personalized heart health coaching. And as a result of our corporate entry, we actually provide these services to everybody independent of ethnic background. Now, this is how we have done. When we look at the first 4,400 participants who have completed our program, we have seen that about 58% have increased their physical activity, 63% have increased their vegetable consumption, 57% have dropped their triglyceride levels, and 62% have improved their cholesterol ratio. Using the ASCVD formula, which predicts the 10-year risk of a cardiac event, the expected 10-year risk for our cohort would be that about 6% of the participants would have been expected to have a cardiac event. Graduates of our program, 98.7% have been event-free. That is, only 1.3% of our participants have had a cardiac event. One of them, I recall, was Vioxx, an agent that actually has been associated with heart attacks. Now, regarding STOP-D, from our first 200 participants, we have done 16 batches. Our program is a 1-year program. 68% have lost weight. 1 out of 3 have reached their 5% weight loss target, which is the target aim at the Stop Diabetes program. And this is actually without prescribing a diet, without prescribing calorie counting. This is actually just by making our participants mindful of the relationship between nutrition and well-being. And 7 out of 10 participants who have been in the STOP-D program have had an improvement in their hemoglobin A1C at 1 year. Now, this is actually more of the same, but in a more numerical fashion. You can see here that again, 58% of our participants have improved their behavior as in relationship to physical activity, and about 63% in relationship to vegetable consumption. When we talk about target, reaching the target, for target, we mean 150 minutes per week of physical activity and about 2/5 of vegetables per day, 1/5 of fruit per day, and 12 nuts daily. You can see that the most improvement has been in the nutritional part, where there has been about 160.9% increment in our participants that have been at target. That is, at the beginning, at baseline on vegetable consumption, there were 986 participants. By the time that we last touched bases with them a year later, about 2,572 participants, 2,572 of the 4,300 participants have actually had reached their nutritional target. In reference to cholesterol, we actually, to those clinical factors, I already mentioned that previously, but again, I show you the raw data on HDL and total cholesterol to HDL ratio. demonstrating again that actually about 65% of our participants without taking medications or prescribed medications by us had a significant improvement in their cholesterol to the HDL ratio, and about 32% of them had the optimal ratio, which was 3.5 ratio or less. Now, our South Asian Heart Center does not only aim to make the community aware of the epidemic of diabetes and coronary artery disease in the population, but also we aim to sort of shed some light as to what is the reason for cardiovascular disease and diabetes in this population. I have listed where we have actually published our papers. We have been to many conferences. We have presented at the American Heart Association. We have presented at the American College of Cardiology. And we have partnered with UCSF, Stanford, the Oregon Health Sciences, and Intel. This is actually a very brief summary of our research findings. We have demonstrated that body mass index, in fact, is the most important predictor of cardiovascular and diabetes risk, and that actually matches well with waist size and waist to height ratio. Some people say, gee, you know, the body mass index is misleading, but along with Jerry Reven at Stanford, we actually published a paper showing that the concordance was very, very close between BMI, waist size, and waist to height ratio, BMI being easier to measure than a waist size and a waist to height ratio. The total triglyceride to HDL ratio is actually a very good surrogate to diagnose insulin resistance, as good as counting the factors that go into and diagnose metabolic syndrome. We have noted a positive association between homocystinemia, inflammatory markers, and metabolic syndrome. We were one of the first, if not the first, to describe the negative relationship between lipoprotein(a) and metabolic syndrome. And in fact, now we know that that Lp(a), low Lp(a) is associated with a higher incidence of metabolic syndrome and diabetes. And finally, we have identified that this issue of coronary artery disease is really not an issue of lipids. It tends to be an issue of this metabolism, and the body mass index, fasting blood sugar, insulin, family history of diabetes tend to be greater predictors for coronary calcification than dyslipidemia. So this is actually what the South Asian Heart Center has done. This is actually a progress report. We invite you all to support and participate in our programs. They're available to all, independent of ethnic background or capacity or ability to pay. Thank you for your attention. These are just the numbers. But behind the numbers, there's people, there are individuals who actually have been able to sort of have been able to sort of modify the way they live and have been able to modify the way they feel. So I would like to introduce Latha. So Latha is actually a tax accountant and an enrolled agent, specialized in corporate tax. After working in public accounting for 17 years, she decided to focus on health promotion and well-being. She subsequently moved San Jose and moved to Cincinnati, Ohio in 2018. And she's now the secretary of Red Sari, which is a not-for-profit organization which works to spread awareness among South Asians of their risk for cardiovascular disease. She's also a volunteer in United Way, helping people with a few means to do their taxes. Now, she came to the South Asian Heart Center at the age of 50 with a weight in 2015 of 160 pounds. By November of 2015, she actually decreased her waist from 38, making her morbidly obese for a woman, to 33. And she was able to lower her body mass index from 28 by September of 2020 to 22.3, which is normal for a South Asian, realizing that body mass index for blacks and whites is the normal cutoff is 25. For any Asian, South Asian or Chinese or Japanese or Koreans, it's 23. That's when you start seeing metabolic disorders. So for a non-Asian, a BMI of 28 is overweight, but for an Asian, a BMI of 28 is obesity. So she was able, with lifestyle changes, move from being obese to being normal weight. She went from exercising about 300 minutes per week to exercising 7 days a week, 60 minutes per day, alternating muscle building and also aerobic exercise. She went from having sugary drinks to no sugary drinks, and she incorporated our nutritional guidelines in a sort of easy way. Actually, it tastes good to eat well-cooked vegetables, eat some nuts, and have some nice fresh fruit. She went from sleeping, and this is the main issue, and this is one of the main issues in America, from sleeping 6 hours a night now to sleeping 7 to 8 hours, which is actually the sweet spot. So it's actually great joy to introduce her so that she can actually share her story with you all.
Thank you, Dr. Molina. I want to start with a quick story. Almost 21 years ago, my 39-year-old brother died suddenly of a massive heart attack. This was a major shock to us. We thought he was healthy. A 39-year-old is not supposed to die of a heart attack. This was not an isolated incident. Over the years, I had been hearing of Indians succumbing to heart attacks at a young age. In 2015, I attended the center's annual gala and heard for the first time that South Asians are 4 times at risk for cardiovascular diseases than any other ethnicity. My husband and I decided to sign up for the center's Aim to Prevent program and get tested. While I was obese and had high C-reactive protein, which measures inflammation in the body, my husband had high cholesterol and was on statin for a few years at that point. We were both at risk for cardiovascular diseases. It was suggested that we make changes on how and what we eat. We needed to begin eating whole grains, more fruits, vegetables, nuts, beans, and legumes, while also reducing sugary drinks and fried foods. We were also introduced to the plate method. Vegetables should be 50% of the plate, protein 25%, and whole grains 25%. At that time, I was already doing some cardio exercises, but I was also advised to add strength training, meditate, and sleep for 7 to 8 hours a night. I decided to change our lifestyle to see if it would make a difference. Initially, it was daunting to change our lifestyle and follow what was suggested for us. I opted for monthly check-in with a heart health coach to help me with the change. As the day of the check-in approached, I felt as if I was going to the principal's office, but my coach was very supportive and encouraging. With their guidance, I was able to overcome the challenge of changing my habits. 6 months into the program, I lost 30 pounds, and more importantly, my inflammatory marker CRP went down from 1.5 to 0.7, which was in the normal range. My husband's cholesterol and triglycerides numbers improved as well. This convinced me that the change we had adopted was working and that it was going to be our new lifestyle. It has been 5 years since we started our journey with the center, and we still continue with what was recommended to us. We eat whole grains, lots of vegetables and fruits, avoid sugary drinks, and eat very minimal sugary and fried foods. We continue to exercise, doing both cardio and strength training 5 to 6 days a week, and sleep 7 to 8 hours a night. Many people have asked me how we have been able to maintain our healthy lifestyle. I'd like to share a few tips. First, embark on this journey as a family. If only one person is willing to change, it's very difficult to maintain it. Second, when you travel or have people visiting, give your diet the highest priority. Continue eating healthy. No one will judge you for that. People have thanked me for serving healthy, tasty food. Third, plan a healthy menu for the week ahead of time and make a shopping list so that you can buy everything you need in advance. Fourth, before going for a party, eat a small salad at home. This makes sure that you don't arrive hungry and binge on those fried samosas and chaklis. Fifth, always keep some raw or dry roasted nuts in your pantry, office, car, or purse. When hunger strikes, go for those nuts rather than chips, cookies, etc. And finally, make healthy eating and exercise a daily goal for 3 months. It is said that if you do something consistently for 90 days, it becomes a habit. I had to do it for 6 months, but that habit stuck. I do remind myself every morning to eat healthy and exercise. I also track what I eat every day, just so that I'm accountable to myself. We all have just one life. Let's make that a happy and a healthy one. I encourage each and every one of you to take the next step and sign up for AIM to Prevent program today. Thank you very much.
Thank you very much, Lata.
Thank
And
you.
Thank you, Dr. Molina, for the very, very engaging, informative talk. That was wonderful. And there were so many take-home messages. I would like to encourage the participants at this point to please post your questions on Q&A, at least start thinking about the questions that you might want to ask Dr. Molina and Lata. So now it's my pleasure to invite Ashish Mathur, who's the co-founder and the executive director of the South Asian Heart Center since its inception. He's created the vision of this whole center and is very, very passionate about it, and you'll find out. He has developed with his guidance an incredible team. As a lot of you would have realized by now, a lot of the information presented to you has been brought to your attention through CWC and several other media. Still, the challenge is with compliance with these things. A lot of us fall short because we're not able to adhere to some of these. And how they've done this at the South Asian Heart Center is a credit to them. He's been a successful founder of several Silicon Valley startups, and he's an engineer by training, but he's done a phenomenal job in the area of heart disease. So without further ado, let's welcome Ashish Mathur for his presentation.
Thank you so much. I really appreciate CWC, Crack the Wellness Code, for inviting the South Asian Heart Center. And we are very, very proud to be a partner with this effort that you have and your team, and Somnath and others. It's really, really a pleasure to participate with you together in this endeavor to reduce heart disease and diabetes within our community. So thank you very much. Today, I wanted to just quickly, briefly talk about the lessons learned over these 14 years. Somnath was very clear about the fact that this would be something of interest for the audience. So I just put together one slide summarizing all of the lessons learned. You've heard from Lata in terms of the lessons learned as well, on the practical nature of kind of, establishing lifestyle. But let me just share my screen and show you what I see happen with participants and the questions that they have. So let's talk about the first thing, which is, the biggest question that comes up, am I at risk? And my question and my answer to most people is that if you are from South Asia or any countries of the Indian subcontinent, then you are at risk. Don't think that, your aging parents are at risk, or your uncle is at risk, or your husband is at risk. You being a South Asian, you are at risk. And it's got to start there. You saw that slide that Dr. Molina put up in terms of PMR or mortality ratio in Indians versus other Asians. And you could see that, we are twice as much or likely to die of heart attacks compared to the others, just in the Asian component ethnicities. The second learning has been that, the traditional risk factor screening, when we go for our physical and we go to the doctor and the doctor says, your cholesterol is fine, you're good with it. That is simply not where it needs to end. And, Dr. Molina talked about the fact that you now have such a great tool to look at, to see where you stand on your coronary calcification. I would encourage all of you, if you are over the age of 40 as a man and 45 as a woman, to just go to your doctor and get this test done. And if they will not do it, we will help you within our program to getting it done. And the third thing, and Dr. Munila alluded to it, is that if everything was the same, the one thing that is really telling about your risk is your BMI. It says more about you than just your looks. And the other thing with it is that a low BMI within South Asians doesn't necessarily mean that you don't have the risk. So watch it really carefully. And even if you kind of get there, you still have to kind of continue working on lifestyle to keep your risk low. The next thing that comes up is, what do I do if I find out, I'm at risk? And what we have found is that one size indeed fits all, almost. So our MEDS platform is such an encompassing platform that it works for everybody. But what changes from person to person to person is the personalization that is done with working with a coach, because everybody needs that personalization. And the question really is, when you ask, a lot of people ask our dietitians, is this good for me? Is ghee good for me? Is brown rice good for me? Is quinoa good for me? The question really needs to be, looking at my profile, is it okay for me to have this or not have this? And that's the personalization that we are talking about. The second thing is that, there is a new paradigm, new meaning it's been about 2 or 3 years old. And many of you might already know it, and it's called the plate method. It was introduced by the USDA to switch from the food pyramid. The food pyramid, was a license for people to pile up their plates. And that kind of really didn't do the trick. So look it up if you don't already know what that is. And Lata actually talked about, the proportion of the food. So everything goes. You can eat everything, but look at how the plate method allows you to decorate your plate. And it is a game changer. 4 times is the magic. We did a study to look at individuals who came through the program and found out that individuals who actually connected with a coach 4 or more times made much more of a significant lifestyle change compared to people who didn't. And it was interesting that initially people would be really scared of the coach. And when the coach would call, they would actually know that the coach is calling from the South Asian Heart Center. They would not take the call, but instead they would go for a walk. So it had the, the right, intent or the intention with it. And when they continued and started building the rapport with the coach, they would not leave the coach alone. That's what made the big change. And then finally, it's a marathon, not a sprint. We won't ask you to actually, train to be a marathon runner. But lifestyle is not about turning overnight. We have so many engineers who come to us and we tell them that we need 150 minutes of exercise in the week. And they all want to complete that 150 minutes of exercise the very next day. And in the end, we find a lot of injured engineers. It is not a sprint. It is a marathon. That's why we have the program be a 1-year-long program so that we can easily start incorporating the changes that will help reduce risk and enhance wellness. And then finally, we hear from so many participants, oh, I know this and I know that. And yes, that's true. Of course, you've read everywhere. And, Dr. Ram had indicated that, through many of these education and awareness programs, you get to know what are the recommendations. But when it gets down to actually doing it yourself, that's when it becomes hard. So you have the knowledge and it's powerful, but it's powerless until you put it into action. And Lata said a beautiful thing that I want to bring up at this point is that planning is everything. And Dr. Molina keeps hitting my head with it, saying, the only way that you can get this done is if you can plan. The next thing is that life happens all the time. A lot of our participants says, you know what, I'm going to lose a few more pounds and then come for the blood test. And it never happens, because from the time they tell us that to the time that they actually, realize they have not done their blood test is because life has happened in the middle. Life happens because you fall sick, your kids fall sick, you've got to travel, you've got other things that are going on, your parents need your help, you have to kind of attend a wedding, you have to do all of these sorts of things. Life is happening constantly. So it's never a good time to, implement lifestyle. You always kind of delay it, and you want to kind of do it tomorrow. So because life is going to happen, you need to really start now. And then finally, it's not the barrier that we see, it's the barrier that we don't. For most people, the single biggest barrier to everything is time. But the question that I want to ask everyone is that if you look at your life today, are you not able to do the things that you love to do and you find time for them? If you love music, you find time to listen to music or play music. If you love, to play with your kids, you will spend time doing that. You find the time to do that. It's just that we don't prioritize lifestyle in the same way, otherwise we would find time for it. And our coach's role is really mostly to find time in your life for the things that are important to have this wellness work. So that's it for the lessons learned. I think these are the top. There is another page full of those, but we can come, and when you come onto the program, we can talk about it. So I hope this has been useful. I thought today that we should really assess everybody's lifestyle meds. And so I want to quickly go through the goals of meds, and so that you can take home with you what the goals are and see if this would work. So the meditation goal is to practice meditation 2 times daily for 20 minutes. So 40 minutes of your time. On exercise, the goal is to get to 150 minutes of exercise per week, but doing it in a regular basis, 30 minutes at least 5 times per week. And then if you could do that, you can add the strength training, which really helps change the metabolic balance for individuals that are struggling with insulin resistance, with fasting blood sugar levels, etc. On the diet side, we have the rule called the 0, 1, 2, 12. And Lata showed us the way for this. 0 is 0 sugary drinks. 1 is 1 fistful of fruit per day. 2 fistful of vegetables daily at a minimum, and 12 nuts daily. So that's the diet goal. And if you can get the plate method in for as many of the 14 meals, lunches and dinners that you have, it will be a game changer for you. And finally, sleep, which is 7 to 8 hours daily. So those are the goals. And let's see how you fare with those. So I'm going to go through assessing your own lifestyle meds as well. So first one is meditation, and the goal of 20 minutes 2 times a day. So this is an anonymous, lifestyle thing. So I would like everybody to take a pencil and kind of write down what your score is. If you don't meditate daily, it's a -2. If you meditate but not daily, it's a -1. If you meditate daily for less than 20 minutes, it's a 0, but it's daily. If you meditate once or twice daily for at least 20 minutes each time, it's a 1. And if you transcend, if you use the transcendental meditation technique, once or twice daily for at least 20 minutes each time, score yourself a 2. So I'll wait a second as you score yourself on your meditation lifestyle score. And remember this number because we're going to add it up at the end to come up with the total score. All right, so super. Exercise. The goal was to get to 150 minutes of exercise per week or 30 minutes 5 times daily. So score yourself a -2 if you do not exercise, if you don't have any structured exercise or physical activity during the week. Yes, 1, you score yourself a 1 if you exercise less than 5 days per week. If you exercise at least 5 days per week for a total less than 150 minutes, score yourself a 0. But if you get to the 150 minutes and 5 days per week, score yourself a 1. And score yourself a 2 if you also include strength training twice a week. So your score would be -1, 2 plus 2. Remember that number, and let's move on. Diet. I told you about the goals, 0, 1, 2, 12. If you remember these 4, no, I do not follow the 4 dietary guidelines daily. If you do not follow any of them, score yourself a -2. If you follow one of the 4 dietary guidelines, score yourself a -1. If you follow 2 to 3 of the 4 dietary guidelines, score yourself a 0. If you do all of the 4 dietary guidelines daily, score yourself a 1. And if you follow all the 4 guidelines daily, plus you utilize the plate method, then you score yourself a 2. Now, if you don't know what the plate method is, you score yourself a 1 or less, depending on where you stand. So score yourself for your diet lifestyle score. That's the 3rd element. And then the 4th element was sleep with a goal of 7 to 8 hours. So if you have insomnia or unmanaged sleep apnea that keeps you from sleeping 7 hours daily, score yourself a -2. If you sleep less than 6 hours daily, a -1. 6 to 7 hours daily is a 0. 7 to 8 hours daily is a 1. Remember, Lata went from the 6 hours to 7 to 8 hours. So she's definitely at the 1. And if she's sleeping before 11 p.m. every day, then that's a 2. So that's your score for your sleep. And that's all of the 4 elements. So now score yourself and add the scores up for meditation, exercise, diet, and sleep, and see where you are. You will have a number between -8 to +8. And that will be telling in terms of what your next steps are. So if you look at your score, and if it is between -8 and -4, you really have to kind of do some deep thinking about, are you really ready to adopt lifestyle meds? Because you're a little bit far from the goals. And clearly, if you are up to it, you will need help to kind of establish it. And so you seek help, figure out who is going to help you get there. For the ones that are between -3 to 1, you have started building up on certain lifestyle factors. And by getting help, you'll certainly benefit and getting some structure to it so that you can find time to do all of the things that we are kind of asking you to look at would help. If your score is between 2 to 4, you may be on a path where self-help will work and perhaps is already working. But getting help and getting some structured help will work better. And if you have a score from 5 to 8, then I would encourage you to actually go to the southasianheartcenter.org and sign up to being a coach. Otherwise, sign up for being on the program. And I've just put our website there in a summary of all the things that we do with you and the several touch points, which are, typically in the range of about 10 to 15 times that we connect with you for 40 minutes each over the 1 year long period.
Terrific. Thank you very much. That was wonderful. I hope there are many participants this evening who are in the Become a Coach group. Embarrassed to say that I'm nowhere near that. So self-help might work, and getting help will certainly work better. These are good guidelines to have. And I think this would be a good segue to our next speaker. A good friend of mine, Sam Suri, who's been a cardiologist in Fremont for many, many years, with a great private practice. He's an interventional cardiologist. And I'd like to get his thoughts on what he feels some of the key issues that he deals with in his practice. I'm sure he has a large enough clientele of South Asians in his practice, and whether a lot of the findings mentioned in some of the studies that Dr. Molina mentioned, whether they would actually apply to the South Asians, or are we worse in terms of some of those numbers presented? So your floor, Sam, take it on.
Well, thank you. By the way, guys, fantastic presentation, very organized. Got to compliment both Caesar and you, Ashish, for doing a great job. We actually are on the more practical side of things. We have a lot of patients like yourselves. We call them patients, not participants, because we actually manage these patients on a day-to-day basis. We're faced with challenges just like yourselves. I don't have, as part of disclosure, any slides here, but I'm happy to take questions from participants and from Dr. Ramachandra as we go. I know things are in cardiovascular disease are constantly changing. I love the MEDS idea in the program for lifestyle management and for day-to-day activities for preventive side of cardiology and preventive health. I think that we're going to adopt what you have, scored and planned and done. We thank you for that. I have about 55 to 60% of my patients of Indian origin, a lot of North Indian patients with a lot of premature cardiovascular disease in my practice. In our practice, I should say. I have an internist, Dr. Lopez. She works with me. She's an internist, and she does a lot of health prevention and so on. But basically, suffice to say that cardiovascular disease is very prevalent in our community here in Fremont. Also, we see a number of patients of other South Asian communities, and we see the same things that you're talking about. We do utilize the CAC score, which is simply your calcium scoring for individuals. And there have been a number of questions that were asked today on CAC scoring. And I think Dr. Molina can address some of those issues better than I can. But I can tell you that we do utilize the CAC score. One of the questions that was asked on the CAC score or the calcium score was, can we reduce or reverse CAC scores? And as far as I know, you cannot. You can slow down the progression of disease, but it's hard to regress it because we haven't seen a lot of data. Now there is lipid data and some other lifestyle data that might be supporting that you might have, but in our practice, if we have a score that's, let's say 400, you cannot bring that down to 100. And we've not seen that anyways. Dr. Molina, I had that question for you.
I was actually researching some of your questions, but in reference to coronary calcification is fixed, meaning if your score is 100, it will not be 50 in 2 years, but tends to be progressive, meaning you follow a curve. There have been papers showing, a paper from Buddha showing that the cardiac event rate was higher in individuals who had faster progression of coronary calcification. The problem is that the addition of statins to the mixture, statin use is associated with increasing coronary calcification. So coronary calcification is something that we do once to diagnose the presence of coronary artery disease, but it's not something that we follow as a marker for success of therapy. The presence of coronary calcification just tells you do have arteriosclerosis. The presence of arteriosclerosis, therefore, places you at risk of a heart attack, and actually would encourage, should encourage you to pay more attention. The benefits of living well are there independent of the presence of a risk for heart disease or diabetes, because living well feels well. And we avoid the use the word eating healthy, because most people think that eating healthy means eating like a rabbit. So we actually encourage people to learn how to cook well, and to eat well.
So question to the cardiologist. How do you manage a patient with increased cardiac risk? Do you think your MEDS will replace meds or medications?
Well, I'll have Dr. Molina answer that, because he's much more into the lifestyle and I'm much more into a combination of things.
That's a very good question. This is not a competition. So, you actually, one of the beautiful things is that, we get disease, but we also get intelligence, and you get creative intelligence. So we actually throw in the kitchen sink. If you're at risk of having diabetes, if you're at risk of having cardiovascular disease, you should actually do whatever has been shown to be of benefit. For example, statins and aspirin have been shown to be of benefit in the presence of coronary artery disease or cerebrovascular disease. We know that hypertension is associated with poor outcomes, that the management of blood pressure with lifestyle and with medications actually is additive. So we are adding things. We are not replacing things. Now, we actually also know that there are individuals who take their pills, smoke their 2 packs of cigarette, and eat at McDonald's. And even though they take their pills, they actually are probably in the frequent flyer program to the cath lab. And we also see that is, despite the best effort, we sometimes see individuals who have one event and then have another event. So because we don't want that, we actually do everything we can to avoid that kind of scenario. And that includes a good pharmaceutical approach that is continuously evolving, because we're all hopefully developing better medications, as well as as a good living approach.
Yeah, a number of patients, Ram, I may interrupt here, a number of patients that come to us for the first time, let's take an example of, let's say, a 45-year-old Indian male, or let's say a 50-year-old Indian woman who has metabolic syndrome, but is not just, basically pre-diabetic, but is also borderline hypertensive. They come in, they have this typical white coat hypertension where the blood pressure is elevated. What do you do in order to kind of confirm that they are hypertensive? I mean, we know as cardiologists what we do. We take 2 readings and kind of stabilize things. What do you do in your practice, and what do you do through this program?
So actually, that's a very good question too, because the fact that white coat hypertension is not benign. What it's telling you is your blood pressure responds to your environment. So it may be that it responds to a nice, soft environment when you're at home in your bedroom. But also you don't know what your blood pressure is when you're discussing your deadlines with your boss. And you don't know what your blood pressure is when you're walking around in traffic. So the way I prefer to call white coat syndrome, I call it reactive high blood pressure. And if we consistently see that this is sort of a common finding, and particularly you see end organ damage, that is, if you have left ventricular hypertrophy by EKG, you have an S4, you have a LVH or left ventricular hypertrophy by echocardiography, if your ophthalmologist says, gee, you know, you do have retinal changes of high blood pressure, you actually have to treat it, even if it's just white coat syndrome and your blood pressure is perfectly normal at home.
Correct. Good point.
Well,
Do you
Dr.
measure
Nath,
in individuals on the regular basis?
Well,
I'm
at the
throwing
South
this
Asian
back
Heart
to
Center, we do.
we
In
do.
my
Okay.
practice, I do. And
Okay.
you know, insurance, you know, Medicare will cover it if you have coronary artery disease and you're following the patient with coronary artery disease with a lipid panel and an hsCRP. They may not cover it if you're just doing randomly. But, you know, the Jupiter trial, which was a beautiful study looking at rosuvastatin in individuals with normal cholesterol and a CRP over 2, showed that the addition of 20 milligrams of rosuvastatin was associated with a significant reduction in cardiac events, particularly in the individuals who had a drop in CRP, much more important than the drop in LDL cholesterol.
Yes.
So actually, for statins, the goal of statin therapy is not just drop on LDL cholesterol. And I tell this to my patients. I say, you know, the problem, you're not taking these medications to lower your cholesterol. You're taking these medications to decrease
Or
risk of a
disease.
heart attack or a stroke, because people with low cholesterol and people with normal cholesterol do benefit. You see a diabetic with a normal cholesterol, they do benefit from a statin, even more than someone with a high cholesterol and no diabetes. So
Correct.
there is actually a lot of data sort of showing that that's the kind of language that we should use.
well, I don't mean to open a whole new can of worms, but all the talk about heart disease sort of refers to the plumbing mechanism of the heart. We're not touching upon the electrical system. Does any of your behavior change with the MEDS affect the electrical side of the heart, such as palpitations or sudden cardiac arrest, those kind of things?
Well, if that question is to me, I can answer it. When you look at, you know, atrial fibrillation is the second most common cause of stroke in America. First being hypertensive cerebrovascular disease, and I think more important than even carotid artery disease is silent atrial fibrillation. 5% of men and women over the age of 65 have actually can get atrial fibrillation. And the most, you know, there are a couple of significant risk factors for atrial fibrillation. One is hypertension. First of all, it's age. Hypertension, diabetes are two, and obesity and sleep apnea are the main risk factors for atrial fibrillation, not including alcohol and things like that. And the fact of the matter is that they are all based on body mass index. That is, you rarely see a diabetic, a type 2 diabetic who has a normal body mass index. You can, you know, you do see them. You see people with, you know, normal weight people with hypertension, but the likelihood that hypertension is related to obesity is very high. So I believe that meds, even though I don't have any science to show you as an outcome from the South Asian Heart Center, is actually would be expected to have a decreased onset of atrial fibrillation because you're having adequate sleep. And sleep interruption, sleep apnea is a common cause of palpitations and AFib. Sleep deprivation is associated with hypertension. Sleep deprivation is associated with increased risk of diabetes on one side and coronary artery disease in the other.
And also age in itself, and more importantly, alcohol consumption. As you know, alcohol consumption can certainly increase the risk of atrial fibrillation in a small subset of patients that have metabolic disease. That's quite considerable as well. And we see a lot of atrial fibrillation in older patients in general, as you had alluded to. Perhaps 5 to 8% of the population over the age of 80 has atrial fibrillation to begin with. So a lot of seniors do, yes. Right. And that can be a problem, yes.
So I'll switch gears a little bit. Dr. Molina, in your talk, you mentioned when you were talking about diet and eating habits, to have a good breakfast. There is so much buzz around intermittent fasting. What do you make of that? If both of you cardiologists can comment on that.
Do you want me to take that one?
Yeah, I think so. Good idea.
That's sort of an interesting thing. And that is because people, when they think about intermittent fasting, they're talking about skipping breakfast. There was a paper that was just published in JAMA Internal Medicine comparing intermittent fasting, eating from noon to 8 p.m. versus regular 3 meals a day per day and a snack. And they found that there was no better weight loss between the two regimens, but there was more lean body mass loss in the intermittent fasting group. Now, on the other hand, there's also beautiful data showing that if you have most of your calories before 3 p.m., you will lose on a calorie restricted diet versus most of your calories after 3 p.m., which is actually what means eating from noon to 8 p.m. because the biggest meal is dinner. You actually have significantly more weight loss if you eat before 3 p.m. than if you eat after 3 p.m. And lastly, there are two papers, one looking at the onset of you're 4 times more likely to be overweight or obese if you skip breakfast than if you don't. And papers have been shown, a paper has been published looking at the time it takes you to start eating in the day as it relates to your body mass index. And the longer you wait to start eating after waking, the fatter you are. So that actually doesn't answer the question, is intermittent fasting good for you or bad for you? But what does answer is that waiting for dinner to have most of your calories and then going to bed and call this intermittent fasting that is good for you, well, the answer is no. Most of your calories should be consumed during the day, and they should probably be consumed following the data before 3 p.m. And so I don't disparage intermittent fasting, but I think actually the timing of it is looked at wrongly.
Yeah, eat like a king in the morning, queen in the afternoon, and a pauper at night.
That's correct.
That's the rule.
Right, that was the old dictum. Yeah,
Yes.
thank you.
And sleep early.
We want to be respectful of people's time. I know we only have a few minutes left. I'll try to take a few questions from our participants. Very quick answers, hopefully. Do ethnic Indian people who adopt Western diet have more incidence of diabetes and heart disease? What do you think?
Absolutely, yes.
Well, if you mean Western diet driving through McDonald's, Burger King, and Kentucky Fried Chicken, yes.
That would change everything.
Now, the other thing though is does the agricultural revolution of India have to do with diabetes and heart disease? And the answer is yes. Yes. Indians have gone from eating the classic, grains of India to just having white rice. And that switch to mass production of rice probably is responsible for the dual epidemic, partially responsible, and Coca-Cola for the dual epidemic of heart disease and diabetes that you're seeing in India.
Okay. Here's another question. Is yoga enough, or does everyone need strength training?
So there's actually, the thing is what is you're trying to, what are you trying to achieve? You want to get enlightened. Well, I think yoga is actually, of the exercises you mentioned, is the only one that may get you
meditation, right?
Now, but if you actually want to increase your cognitive capacity and decrease your risk of dementia, you have to do aerobic exercise. If you want to be able to get out of bed and get out of a chair as an elderly man or woman and not have to use a walker, muscle strengthening is important. So you also have to be flexible so you can bend down and sort of tie your shoes. So there's this is again not a competition. You have to pay attention to aerobic exercise. You have to pay attention to muscle strengthening exercises, and you also have to stretch and be flexible.
Correct.
And maybe you want to get enlightened too, so that then, it is easier to get enlightened than to avoid disease.
Great. Well, we got your comments about coronary calcification that's fixed and there can't be any change. What do you make of the soft plaques that exist? Do they tend to shrink down?
They actually can. So
yes.
The way you can look at, and actually as an interventional cardiologist, most of the time when you go to the cath lab to treat a heart attack, you're mainly dealing with soft plaque that has ruptured. So that's such an easy, you're putting the wire in and just sort of you're sort of like stretching,
Yeah.
dealing with sort of soft coronary arteriosclerosis. Now, that kind of plaque is actually in play. You can actually shrink it, you can decrease the inflammation, you can stabilize it. It can subsequently become calcified and non-obstructive, or it can progress and lead to an obstructive lesion, or it can rupture and lead to a heart attack. That is not measured with calcium scanning. But what we do know is that if you have high coronary calcium scanning, you have high calcium because you have had a lot of soft plaque that predated that hard calcium. So the presence of coronary calcification suggests that you also have a lot of soft plaque. You can actually stabilize your coronary artery disease and actually reduce the presence of soft plaque. The way I see it, and actually I've seen this before, I've seen patients with a CT coronary angiogram showing, a mid-RCA lesion, and then for reasons that are just life happens, as Ashish mentioned, 6 months later, going in finally to the cath lab, done an angiogram, and there's no longer any lesion there. So it just, that is actually, coronary artery disease is a dynamic process. It's like having acne. You can have one pimple today and it may go away, or you can actually have a big carbuncle and get into trouble.
And the goal is basically plaque stabilization or plaque regression. And that's the idea behind treatment. And thank you. That's great.
I know we're almost coming to closing time here. If I can ask each panelist, what would be your 2 take-home messages from this evening's session? Dr. Molina.
Well, I think Dr. Molina first, yeah.
Actually, one of the things that I have learned as a physician and as a cardiologist over the years is that paying a little bit of attention to yourself goes a long way. And actually, that's really the main, I would say that is actually the main takeaway, is sort of paying a little bit of attention to yourself. And then the next, the correlate to that is, are you feeling strong? Are you feeling well? Or are you feeling tired and weak? So that actually, with that in mind, then the rest actually falls into place.
I actually enjoyed Dr. Molina's presentation. It was awesome. I think the 2 takeaway messages are, and I learned something here too on the meds. I think that was an excellent part of the presentation. And then secondly, I think the takeaway would be for everybody, essentially, get out there, start jogging well, exercise, sleep well. That's critical. That's very, very important. And meditate. Great.
And Lata's story was great, very inspiring. Lata, if you have to reinforce 2 key points from...
My 2 key points would be eat well, exercise, and 3 key points, sleep.
And Ashish.
So I'll bring up the topic that nobody's talked about, and that is meditation. And I can tell you from somebody who has had the experience of a heart attack, the thing to me today that has really helped make a big change for me is meditation. And I have to thank Dr. Molina for it, because he actually held me by the hand and dragged me into learning meditation. And I can not thank him enough for the greatest tool that he has given me to address stress. So if this is something, don't look at meditation as a tool for spirituality. Look at meditation as a tool for health. And that changes everything.
Sage advice. Thank you. Please join me in thanking all of the panelists for an excellent, excellent session today.